So a very warm welcome on behalf of EuroELSO. This is our webinar on the one-year experience with COVID-19 in European ECMO centers. You may have been waiting for Lean Verkamst today on the perspective of the ECMO technician. She wasn't available on short notice, and this is why we are extremely thankful for our faculty to come in on last second, so to say. So next slide, please. Our faculty consists of Roberto Lorusso, our previous president, Jan Bělohlávek, our current president, and Brijesh Patel from the Royal Brompton in London, who's the scientific lead there. And our agenda, next slide, please, will be at first a presentation of the current ELSO survey in European ECMO centers given by Roberto. And then we will hear the London experience. I also have the pleasure to show a few slides on the Vienna perspective. And then eventually Jan will show some cases that will directly then lead into the discussion. Now, while you're listening to the presentations, you may at all times enter questions into the webinar tool, and I will take them and pass them on in the discussion that is taking place after the presentation. So as a first speaker, I welcome Roberto. Thank you very much for being with us today, and we are looking forward to your slides.
Thank you very much, Peter. Thank you for the kind invitation. It's always a pleasure, and I thank EuroELSO for the opportunity to show our very latest data of the EuroECMO COVID patient. So as you know, we started this when we had the perception that this pandemic was going to hit really remarkably our healthcare, and we started just at the very end of February of last year. And you can see that we have been really astonished by the kind of interest all over Europe, and not only strictly Europe, but also outside, but all the, so to say, European-based and related countries. So you can see we have all the countries are participating with a lot of centers, and we were really pleased to have such a big interest along the time, because I want to stress that you can see that now we have more than 190 centers. We started with less than 50 at the very beginning, and along the way we had a lot of really good appraisal of this study, and so a lot of centers joined even at the very last moment. So again, I think this is really a good example of how we can do the work together. And just to show you the trend of numbers, you can see the first weekly report was released on March 21. We started at the beginning of March, and then we started with the very first. Actually, here you can see we had the 68 centers, and at the end of the first wave, which was September, we had more than 1,500 cases implanted, and then we had still a rise, as unfortunately we know very well now, the second wave, and you can see that we reached almost 3,400 cases overall, the first and second wave. And unfortunately, we know that the situation is still ongoing, and you can see here that we reached 4,000 cases. So the situation is still unfortunately running, still present, and we are collecting as much information as possible for this. But this, again, you can understand 192 centers and more than 4,000 patients. But what about the results? So again, you can see here the winning rate for the first wave, which was around 55%. And we submitted this information to intensive care medicine during the first wave of pandemic. And you can see during the second pandemic, the situation changed a little bit and went a little bit worse, as you can see. So this is already an information that I can give it to you. So here we have almost 45%. So this means that we can just speculate that apparently the second wave was maybe not unexpected as the first, but unfortunately it hit much more. And you can see that the third wave, the situation is a little bit the same, remain quite stable as the second wave. And you can see here again the winning rate was almost the same as the second wave, so around 45%. So this is already, I think, an information that we are providing. So the first wave certainly shocked us in many ways, and but I would say the reply and the kind of patient we were treated were a little bit different from the second and the third wave. So this is regarding the winning patient. But let's see about the disease trend and rate, because of course, while I'm speaking, still a lot of patients are still on ECMO. So you can see here that the mortality rate on ECMO was around 39%, and the mortality, because this is an important information where we provide after ECMO weaning, so after successful ECMO weaning, was 4.6%. And this is another very interesting point to underline, because if we compare the second wave, again, you can see a little bit higher mortality rate as compared to the first wave. But regarding the after weaning mortality rate, it was certainly lower. So it looks like that the patients weaned from ECMO in the second wave, and this was also confirmed in the third wave with the same mortality rate on ECMO as the second wave, and also the mortality after ECMO weaning. So if we can make again a comparison, I think that the first wave we had a little bit higher weaning rate and a lower mortality after weaning. Instead, this is what we had a higher mortality rate after weaning. Instead, after the second and third wave, we have a lower mortality rate after ECMO weaning. Regarding other information like the type of ECMO, I think that I don't want you to follow other things, just to say that along the first, second, and third wave, it's actually almost the same. So we had around 91, 92, 93% of VV ECMO and very low rate of alternatives like VAR or hybrid ECMO. So again, between 7 and 7.5%. So again, this is another very important information to look at and discuss and maybe interpret. And what about the other very basic, because these are the basic information we collected. Now we are collecting all the details of the patient population, also the 6-month follow-up. So I can tell you that now we are collecting this information. So a complete data set plus 6-month follow-up. And you can see that at the end, as we know, the mean age was rather low, although we had patients in the elderly group, like 80, but you can see again, the vast majority of patients were male as compared to female, and this was in the first wave, in the second wave, and third wave. So nothing changed in this respect, with again a predominance of male population and the mean age around 52, 53 year old of the patient treated. So I think that these are the basic information I'm going to give you today. So this was the release of yesterday. So again, we have been working with this project more than 1 year, and I think we gave a lot of precious information. And we hope now, with the collection of the details of the treated patients, together with the 6-month follow-up, to be able to provide a very, very detailed analysis of the patient. And then we will, of course, compare the first, second, and hopefully very short third wave, because this is really our concern now, But I think we are going to have a lot of very precious information regarding this experience. Thank you very much for your attention.
Roberto, thank you so much. I suggest that we have the discussion on all the different presentations at the very end. I think I can say on behalf of our entire community, I would like to thank you for putting so much effort into this important project. We learned so much from that, and it undoubtedly that's a massive success, and beyond this period right now, I think it bears the chance to bring us even closer. As you mentioned, the huge number of centers that are part of that. Thank you so much. That's going to be very valuable also for the future, and I believe also, even though that was mainly triggered by you, it also can show what sort of leadership EuroELSO can have here in our regional aspects.
Definitely, I want to thank all my group, but also EuroELSO steering committee, which supported this experience. I think, again, we were really at the very beginning of the hit, so I think we did, I think, a precious job providing information every week. Thank you again for the opportunity.
And of course also thank you to all of the centers who took the extra mile and the effort to, even at difficult times, contribute their data. Thank you so much. So as the next speaker,
can I just touch very briefly on behalf of steering committee? This is a major project of EuroELSO, and we keep it really in mind, and I'm inviting everybody who is not providing data, I would like to collaborate. This is the right time to join our group and provide the data, and we will share it, and we will initiate a lot of sub-studies so everybody might have a chance to participate actively. Thank you.
So as the next speaker, I would like to welcome Brijesh Patel from London. This is your stage. Rich, I think you have to unmute your microphone.
Cardinal mistake, sorry. So thank you for the invitation to talk today and talk about the UK ECMO response, but also some of the work that we've looked at in the patients that we've seen at the Royal Brompton, and particularly within the pathophysiology of this disease. So just a bit of a, I suppose, a coverage. The UK ECMO service really has kind of 5 centres within England and 1 within Scotland. And during the COVID pandemic, we had 2 additional surge centres that also were commissioned. And this is commissioned from NHS specialist commissioning, higher specialist commissioning. So a lot of the ECMO delivery is centralised within the UK, with every ICU referring to each of the centres within a geographic area. So as you can imagine, we're delivering the ECMO service during a pandemic was 10 years after the first flu pandemic, which effectively developed the NHS England service. The key data that really came out of the UK was actually from ICNARC, which really upscaled their delivery of data on a weekly basis, really to try and help us communicate as to what was happening in different regions within the United Kingdom, and particularly within England, Wales and Northern Ireland. And you can see here that the first wave going up to the 31st of August, London saw initially the brunt of the initial wave, which then spread across England. And in the second wave again, from the 1st of September, but really particularly within January, February time, was when we saw a significant increase in the number of admissions. So I'm going to divide the 2 waves within that, and then go on to just discussing the criteria that we currently use. So this is to give a bit of context to the data that we will present and the way in which we have seen this, the experience within the United Kingdom. This paper by Luigi Camprota and a number of the other clinical leads suggesting a consensus for the referral and admission of patients that were used within the NHS ECMO service. I'll refer you to that, but effectively looking at the criteria for referral of ECMO, we really needed to ensure that ECMO provision and delivery was equitable. And so each of the centres that delivered ECMO really sung from the same hymn sheet in terms of the referral criteria and the acceptance criteria. And during the pandemic, actually, there was a significant increase in the amount of collaboration that occurred between each of the centres with weekly meetings. And I kind of congratulate the clinical leads and the wider ECMO community within the UK that this collaboration occurred. It was a very challenging time, particularly with the number of referrals that we had. This is current data from the commissioners, really, which I got an email on today. And this is, I suppose, extrapolating some of the two major databases that we have, the ECMO referral database, which is an online referral system which captures a lot of the data, with the ICNARC database. So if we look at wave one within the ICNARC reports that we saw nearly 7,900 patients that received invasive mechanical ventilation between March and August. Of those, nearly 1,600, so that's 20% of patients were referred to an ECMO centre for either advice for severe acute respiratory failure or referral for ECMO. And within that, only 4% were placed on ECMO because they fit criteria. Wave two, as you can imagine, was a lot worse. Nearly 25% of patients were referred for ECMO or advice from the nearly 13,000 that received invasive mechanical ventilation from the ICNARC report from a few weeks ago. And 361 were placed on ECMO, roughly 3%. And so in total, the ECMO network took nearly phone calls pretty much every day, and at peak in the first surge, I remember there being nearly 20 referrals within a day and active discussions ongoing, where we had 23% of all patients that were intubated referred to the service. And so you can imagine the amount of effort and work required to be able to deliver that sort of service, but also not only retrieve the patients to the centre, but also look after the patients within the centre itself. Now on that, because we were receiving so many referrals, we started really quite acutely a real observational cohort study to try and understand the trajectory of patients that we were seeing, because we really struggled with trying to advise patients about how long we should prone for in terms of responsiveness and when we should go on to ECMO. And so this is latest data that's in press but should be published in ICM over the next week or two, looking at really granular data from as many sites that could contribute daily data to look at the natural history and trajectory of these patients that were invasively ventilated during the first surge. We took 17 UK ICUs across England and Northern Ireland, for which we got daily data, and we effectively got 633 patients there to look at how we managed these patients. What did we do to them? What was their physiology like using usual clinical data? And many of the publications so far and the outputs have looked really at admission data within the first 72 hours. And what we wanted to do is look at the whole trajectory of patients going through to enable us to understand when patients should go on to ECMO after, and all the interventions that have occurred prior to going on to ECMO, partly because of the specialist nature of our service. And one of the things we concluded was that analysis should include more time series analysis because of the dynamic nature of the ICU stay. And so in collaboration with the AI for Healthcare team at my University Imperial College, we used a machine learning and explainable AI analysis to look at daily clinical parameters. And you can see the daily clinical parameters listed here that we collected from each of the 17 ICUs that could contribute. And now we've got more data being inputted for the second wave. But we used a SHAP model basically to try and explain how a machine learning system weighs the importance of each of these parameters in terms of mortality prediction. And over the first week, to try and understand which parameter becomes more important. As you can see here on the left, what we found is that our machine learning model, as it incorporated more data over the first week, its accuracy for prediction of outcome increased. And in the second on the right, we could see that there were certain parameters that increased in importance in predicting outcome. And one of the things that came about was PF ratio, so effectively oxygenation really determined the outcome of these patients. So these patients had severe hypoxemia, and that explained to a certain degree why nearly a quarter of intubated patients were referred to us, having been managed conventionally. These data I'll briefly go through, but hypoxemia varied considerably. If we look at COVID patients versus registries such as LungSafe and Berlin definition registries, what we found that COVID patients were twice as likely to worsen in terms of trajectory, and only a quarter of them resolved their oxygenation within the first week. If you resolved your oxygenation within the first week, compared to those that didn't, their outcome was much worse. So and it was a 60% versus 17% mortality really between those that didn't resolve and resolved, which is quite stark. We also took a number of phone calls to advise on prone position, and actually many patients didn't respond to prone positioning. So only 44% of patients that received prone positioning had sustained oxygenation response. Responses were also better if you were proned earlier, and we know within our data set that there were a lot of patients that missed a proning opportunity, and then their responsiveness decayed over the later they were proned, but also non-responsiveness to proning was associated with a much worse outcome. And these non-responders were older, they tended to have a higher lactate, had higher lung injury through peak inspiratory pressure use, but also higher vasopressor use, and a much worse PF ratio. We needed to look at why we thought this was occurring. It was slightly unusual compared to, let's say, the flu that we see every year, and there were some differences whilst we use similar treatments. But what we did find is that within our center, we use a lot of we scan patients effectively as they come in, and with collaboration through our radiology team and our wider MDT, what we found was that there were significant dilated peripheral vessels within the lungs of these patients, with significant perfusion abnormality on dual energy CT, which effectively maps iodine perfusion within a CTPA. And you can see here in image C there that there is significant hypoperfusion, particularly in the peripheries, which is associated effectively where these dilated vessels are. And what we think is happening here is that these dilated vessels really become quite tortuous and have a similar manifestation, similar to pulmonary thrombotic angiopathy, where you get neoangiogenesis and what we call a vascular tree and bud, and you get new vessel formation within the lungs themselves. And this new vessel formation, vascular tree and bud, increases the longer you're on invasive mechanical ventilation. So we looked further within our cohort to compare the COVID patients versus the viral pneumonia patients, and this explained this phenomenon potentially explains partly one, the length of ECMO run. If this is a thrombotic angiopathy that's occurring within the lungs, it takes time to clear those vessels up to improve gas exchange. The length of ICU stay was significantly higher, but also the incidence, as we all know now, of pulmonary embolism was really nearly 2.5 times more. However, patients surviving to ECMO decannulation was actually reasonably very high. So we have a 83% survival to ICU discharge within our cohort, which is not too dissimilar to the viral pneumonia cohort. And so if you wait long enough, many of these patients do resolve. However, as Roberto alluded to, the second wave was very different. These patients were, the first wave potentially were also steroid naive, having not had the dexamethasone prior, and so our introduction of steroids within, maybe a bit later within the ECMO run, allowed them to respond and resolve. But the second wave, their survival to decannulation was less, 71% versus 89%. But also the duration of ECMO run we're finding within the second wave were much longer. And this is data from our center, and effectively not really any demographic changes or any changes to the service really per se between the first and second wave. And so I think there's a lot of analysis that we need to do about why the first and the second wave may be different, and what future waves may lead to changes in the way in which we need to manage these patients going forward. So really take-home points with some of the work that we've done is hypoxemia is a major driving factor for mortality in COVID-19. The usual ARDS interventions show pretty unpredictable responses, including high peak, which I've not shown here, but for instance, proning. And pulmonary angiopathy and the thrombosis may be a pathobiological explanation for this. The UK ECMO network was significantly challenged during both waves. Nearly over 20% of all ventilator patients referred. ECMO criteria was strictly adhered to and really adapted to enable equity of delivery across the whole of the nation. The survival rate of patients with COVID-19 in the first wave is identical to that reported for other causes, but wave 2 may be significantly different to wave 1. And I think we need to have an open discussion as to why that may be. These patients were intrinsically refractory to already established therapies that were introduced during the COVID pandemic, such as steroids and tocilizumab, and potentially more discussion on the duration of non-invasive ventilation and ventilator-associated lung injury prior to them receiving ECMO, and those differences between wave 1 and wave 2. Just like to thank patients, families, funders, and the wider team, because this was a huge amount of effort clinically as well as academically to try and get these data. So thank you.
Thank you, Brijesh, and congratulations for your presentation for your clinical outcome that you achieved, all the organizational methods, and of course for your scientific efforts here. Just a personal note, I have the pleasure of working with Brijesh on a Horizon 2020 project that the team in London is running, and I really know how much this guy has been working over the last month. So thank you for being here today with us and sharing some of what we have learned already in the meantime. So if you allow me, I would like to just show very few slides from my center, and I hope that you can see my slides. Maybe you can give me a sign on that. Can you see that? Anyone can comment on that?
No.
Oh, not yet.
Not yet? Okay. If this doesn't work, I can also do that without showing the slides, because it's just some notes more or less. So we are currently in Vienna in the middle of our third wave, and number-wise, we have not been struck as hard as we have been now. As of yesterday, we have performed 98 ECMOs in Vienna General Hospital. Just a typical epidemiology, I believe. The median age is 57, and duration of ECMO support 14 days. We have a preliminary mortality rate of 33%. Currently, also 1/3 of the patients are still in follow-up, as during the last weeks we have constantly been treating between 25 and 30 patients on ECMO. We have changed our service quite dramatically because we have by now 6 intensive care units fully dedicated to COVID care, and what we basically do is we admit the patient on a tube, put them to ECMO, and then exchange the patient against the next ECMO candidate once they're weaned of ECMO. So that, of course, changed a lot around the way we do intensive care and what this means for non-COVID patients and all other teams in our hospital. I would like to mention that of those 98 8 ECMO patients, we performed 13 lung transplantations in the meantime. Of these 13 patients, 12 went well in terms of 6 being discharged to home and 6 still within the hospital in ICU and non-hospital patients. We have evaluated 45 patients and 15 of these patients have been accepted, meaning that there are 2 on waiting currently for organs, and another 9 patients are currently being evaluated. If you wonder why are there so many patients in Vienna, you may have heard that in Vienna, as we're having one of the largest transplant programs worldwide, we have a system of center allocation allowing us to service patients with a relatively short waiting time on ECMO once the indication is made. And if you are interested in some of the background ideas and thoughts that we have on that, you may want to look for a publication by Barat et al. In Lancet Respiratory Medicine, published online only recently. This was led by the team from Northwestern Chicago, but also joined by our group around Konrad Hörzenecker and Walter Klebetko. And I would like to also thank them for sharing their data with us. And eventually, this is my take-home message from all of this last year. We really came together much closer, especially in the third wave. Improved communication and organization starts with the colleagues that refer patients to us from other hospitals, from other wards, from intermediate care units that are incredibly struck lately. This involves all different professions, anesthetists, medical intensivists. We need the surgeons, infectiologists. I cannot even imagine all the doctors involved. Of course, without the nurses, none of that will be possible. We have great cardio technicians, physiotherapists that are incredibly helpful. And it's also the time after the ICU that other hospitals, they take their patients back to their ICU. It's post-COVID care in the hospital, it's rehab. And of course, a major part in our hospital is the non-COVID patients, where it's become really difficult to take care of them. And also a lot of colleagues that are mainly taking care of these patients do an incredible job to organize everything at the very best possible, which still is very difficult in times like these. So with that, I would like to close my couple remarks and hand over to Jan to share their experience in Prague. They have been hit pretty hard in the last months as well. And we are looking forward to hear your slides and also the cases that you want to share. Thank you for being here, Jan.
Thank you. I'm trying to share my screen. Can you?
We can see your slides, Jan. That's okay.
Yeah, perfect.
Yeah, we can see.
Perfect. So thank you very much. Yes, exactly as you said, as Roberto and Brijesh showed, the COVID changed completely our clinical practice and intensive care. And I'm just going to share with you a couple cases that were interesting. This is the first one. This is a special gift to Roberto. Roberto, we had this case of COVID. The lady had a mild pneumonia, but she was in stress, and 14 days of having COVID and having advanced hypoxemia, she was put on high flow nasal oxygen. Then she had to be intubated. And she came to our center for the heart failure, actually. She was admitted in cardiogenic shock. She was put on levosimendan, and she had a severe left ventricular dysfunction with ejection fraction of 25%. And as you see, very high filling pressure. And this was her left ventriculography because she had some ST segment changes. And so we did coronary angio, which was completely normal. And this was left ventricle. So if you want to have a discussion on that, kind of quiz, what do you think? What would you do with this? Or just anybody of you?
But was it only left ventricular dysfunction? That's quite peculiar.
It was only left ventricle, yes.
So this is certainly a good indication for Impella, or you can start with a balloon pump, and then if you see any decrease in diastolic pressure, then you go to Impella after balloon pump. I would say if you need, of course, more. I mean, you cannot cope with the ventilation. I think that at the end, VA ECMO plus Impella could be also, or VV ECMO plus Impella. That's also a very good combination.
We actually didn't have a major problem with oxygenation in this lady. And to be honest, at the moment she came and we didn't have any ECMO available at the moment. All were occupied by other patients. So from these two reasons, and moreover, with this very high level of filling pressure, we just put the lady on Impella, exactly as you said. So this was next day. We inserted Impella, and she did well after I think 5 days. She was explanted. Her ejection fraction went normal, and it was a typical case of Takotsubo cardiomyopathy due to the stress and hypoxia, which was solved by healthy unloading and mechanical support by Impella in the range of 2 to 3 liters per minute. So it was one of the first interesting cases. The second one is right here. This is from my colleagues from General ICU, from Martin Balik's team and his colleagues. It was a gentleman who was 50 years old, and he was put on a VV ECMO in the regional hospital where we were called for cannulation for severe refractory hypoxemia. And he had severe COVID. He was not responding to prompt well, so he was put on VV. After he came, he was very unstable, so he was put on VA. And here you see his left ventricle. It was a month ago, and you see on the left-hand side how his left ventricle was overloaded, and basically no pulsations, closed aortic valve, and severe smoke in the left ventricle. At the moment, I was called, and we were prepared to put in Impella, and we said, okay, before we set up a team, let's just put the patient on the dobutamine. And he improved basically immediately. So we decided to wait a little bit, and now you see his echo 12 hours later down here, just on the dobutamine, how fast the recovery from the almost no movement on the left-hand side to the wonderful hypercontractile left ventricle on the right side. So I'm showing this as a contrary to the previous one, that sometimes the recovery, which we would not expect, may be very fast, and we may wait a little bit and try conservatively to solve it without the invasive measures. It was a real interesting case of a recovery after just a couple of months.
May I ask you?
Sure.
May I ask you? So did you try the same with the previous patient? So you try always with the dobutamine stress test with the patient to decide whether to proceed with the Impella or not?
In the previous patient, in Takotsubo cases, we are trying to not use any inotropes. We are trying not to use any beta mimetics. So the dobutamine is not good because there's a theory saying that Takotsubo is caused by too much of catecholamine. So we are trying to get rid of those. So in the case of Takotsubo severe cardiogenic shock, we are using just vasopressors, occasional levosimendan, and then we go for mechanical support immediately. And there's been several reports showing this should be done like this. You can even worsen the situation with the dobutamine and severe Takotsubo cardiomyopathy.
Jan, can I ask how many of these cases you have, I suppose, severe lung failure with significant cardiogenic shock, which then just placing initially on VV ECMO to improve the oxygenation and the pulmonary vascular flow, did you then find that the cardiogenic component resolved? So that's been some of our approaches, kind of going out on retrieval, seeing patients as such, putting them on VV with a view to assessing whether cardiac responses, particularly with the high, let's say, intrathoracic pressures through ventilation. I just wonder what your experience of that was.
It's been, as per our experience, we are somewhere around 90 COVID ECMOs, mainly VV, and we had, I think, 5 cases where we switched to VA for a certain period of time, usually back again to VV. And there was one patient who was VV, VA, things like that. And I think Roberto will confirm that from our data from Europe, it looks like we are having around 5% of VA cases in this large series of patients. Correct, Roberto?
Yeah, right, absolutely right. Again, I think that will be a very interesting topic of investigation and data analysis for the future. I think certainly for the EuroECMO COVID study we will do, and trying to understand if in case the VA ECMO or hybrid, so VAV or whatever, has been used in a really lower rate than needed. I think there is this feeling, but of course we have to analyze the data first.
Okay, now I have a present for Peter. Actually, just going to the next slide. Hopefully. Okay, so we have seen a lot of pictures like this, H1N1 and now COVID and severe ARDS, and you have mentioned the possibility of lung transplant. This is a matter of many debates. So the question is, when we can see the lung healing in a severe COVID. So this is a case of very typical one, a young male born 1984, who had a severe ARDS, mechanical ventilation, plus VV ECMO. He was on VV ECMO from March 1st to March 23. And the picture you are seeing right now is on March 12th. It was day 12 on mechanical ventilation plus VV ECMO. So 12 days of very invasive ventilation plus VV ECMO, such a severe morphologic picture. So Peter, you had a couple patients transplanted. How long do you wait before you decide in the cases like this? He had a single organ failure. He was hemodynamically perfectly stable. And we had actually, at that moment, 2 episodes of sudden oxygenated thrombosis. So we had to emergently change the circuit. And overall, he had 3 episodes of this. So would you wait still in this case, or would you at least consider the lung transplant referral?
So this patient is just about 3 weeks on ECMO, right?
At the moment, you see the picture was the 12 days on ECMO.
Yeah. So I would not consider it at day 12 to evaluate the patient. I think all of these consolidations are potentially reversible, and unfortunately I couldn't show you the slides, but I can give you the data of the 13 patients that we transplanted, because you were asking about the time period that we wait for. All of these patients had been on ECMO, and the median day of ECMO support prior to lung transplant was 41 days in our center, and that's what came out from this, you could call it consensus from the paper in Lancet Respiratory Medicine that I mentioned, is that even though there are not any hard data to support that, we should at least wait for 4 to 6 weeks on ECMO support to allow some lung healing, unless there are situations which make it very unlikely for the lung to heal. When we had the first patient that we transplanted, that was referred to us from a different ECMO center in Austria that doesn't do lung transplantation. She apparently had changes to the lung. That case also had been published in Lancet Respiratory Medicine. That made us instantly believed that this lung would not be able to recover. So the one side of the lung was completely necrotic. She did not have any perfusion anymore in there, which also was correspondingly found within the transplantation progress, so that there was almost no, the tissue was sort of gone, right? But otherwise, I think, especially if I only have that one slide with the lung that you showing from the CAT scan, I don't think there's any sign that would at this stage tell us that this lung could not more or less completely recover. So don't go for that too early.
Yeah, thanks. Very glad to hear this. And for the audience, Peter didn't see the pictures before, so exactly what you are saying. And I'm glad to hear that teams have to wait for at least 4 to 6 weeks, which is sometimes very discouraging. So people are impatient in waiting. So we waited, and this is March 26th. So 14 days later, you see a nice signs of healing, and this is actually day 3 post ECMO. When ECMO was weaned, and ultimately on April 4th, so you see this is a recent case and the patient is still at our ICU. This is post-decannulation, so almost complete recovery except for upper parts of the lungs, mainly the left one. So exactly as you are saying, we just have to be patient and wait for at least 4 weeks and to give a chance for healing. Unfortunately, a lot of patients don't actually make it to those 4 weeks, and they have a different complications. And I apologize for a minute because I was not sure whether I'll make it, but I have a special case for Brijesh actually. And if you give me a second, I'll share again. And because you showed a wonderful, do you see my screen?
Mm.
Do you see the chest X-ray?
Yeah, we can see the
great. So, and this is for Brijesh, especially because you showed a nice data on the angiopathy and thrombosis in situ. So this was, now this is still, she is alive, a lady, 74 years old. She was 1 month post-COVID, and she was brought up by the emergency service for sudden shortness of breath. She was dyspneic. And the cause of this now was very obvious on the first moment. So she had such a large mobile thrombus in the right atrium and the right ventricle. On the other picture, you will see again the thrombus. However, you see there was a thrombus embedded into the septum and prolapsing into the left atrium and intermittently into the left ventricle. So this is long axis. You see left ventricle, left atrial mitral valve, and a large thrombus prolapsing from the right side over the patent foramen ovale to the left side. And so my question to you is, or to all of you, what do we do with the patient? So we would just keep her on heparin. She was short of breath. She was dependent on oxygen, and she had a significant right ventricle failure. And would you consider thrombolysis, or would you send and refer her for surgery?
Yeah, and I think so in this case, I mean, I would consider thrombolysis.
I mean, it's just like everyone, pulmonary embolism, acute pulmonary embolism. So.
And so surgeon would thrombolyze, or would you operate on her, Roberto? What would you do?
The only thing is that it's floating into the left side, so that is the risk. So I think that I would like to see a little bit better the echo, but if you see quite large in the left, then I would go for surgery.
Yeah, this is what I can show you. Basically, this is what we have seen. So large thrombus in the right side and severe right ventricle, the right side, severe ventricular dysfunction, and she had also thrombi in the pulmonary artery on the CT, which I'm not showing here. And you see this large thrombus. It's not seen over here, but from the other projection right here, you see the thrombus is prolapsing here to the left side through the interarterial septum. So what about Peter? What would you do?
So you're including me into the brawl between an intensivist and a surgeon, right?
Yes, exactly.
My connection is really bad right now. No, if that was an acute event,
Yeah.
and nothing that is smoldering more or less and growing into this massive problem clinically, I would go for thrombolysis.
Mm-hmm.
And the more this seems to be a chronic problem that's been evolving and not making me hopeful that this could be actually responding to lysis, then I would rather think about talking to an interventionist or a surgeon, right?
Okay, so to be honest, I was also in favor of thrombolysis, but I was prevailed by my colleagues and who preferred surgery, and also by our surgeons who were keen to operate on this lady. So we have sent her for surgery, and this is what we have seen in the surgery. This is a thrombus when it's pulling out from the heart on the left-hand side. And this is all the thrombi which have been removed from the right side of the heart and from the pulmonary artery. And you see this is a combined kind of fresh and the older thrombus. So retrospectively, I'm afraid that if we have thrombolized her, maybe we might get a large embolism on the left side, meaning risk of stroke or whatever else. So retrospectively, I'm glad we did not thrombolize her, and she had an uncomplicated outcome. So she went well, and the third day she was on the standard ward. So exactly as you said, I was hesitating to thrombolize her. At the end, she was okay with surgery. Okay, this is all my cases, and from my side, inviting you to our virtual congress, and that's all. Thank you very much.
So Jana, I just wanted to ask about your lung healing, and I think Roberto as well. How much steroid use have you given on ECMO? So high dose pulse steroids. Just in terms of. Okay.
You just keep the same dose as before.
And so in the UK, I know there's a trial going on, Anders Pernes is doing of 6 versus 12, and I know the Dexarades use 20. Obviously, prior to ECMO, this is where we're seeing a lot of patients with 6 milligrams. But I think a lot of our practice is when we've done serial CT scans, we've found a lot of non-dependent consolidation, so an organizing component. And through our MDT, we have used higher dose of pulsed methylpred to try and resolve some of those. I'm just curious as to what other people's views are on that. I know we need a good prospective trial on ECMO to be able to look at this, but that's something that we've had practice in over the last kind of 4 or 5 years.
Well, we have been doing that quite often in late RDS patients, COVID on ECMO, starting around, let's say, week 3, admitting that we do not have data at all on this. Our impression was that at first we saw some contemporary results in terms of patients getting better. We have not looked at that retrospectively in detail, but my feeling is that since they have already received their DEXA front up, response is hardly measurable, but we still do that at some times because we're desperate. I mean, some patients won't become lung transplant patients because they have exclusion criteria, very, very apparent ones. But my feeling is that we have not seen great results lately.
And do you do a trial of non-responsiveness to steroids prior to transplant, or do you make that decision quite independent of that?
I can only talk for the patients that have been treated in my ward, and they all had been through at least one cycle of high-dose steroids, at least, yeah. What we do is when we give that unproven therapy, we want to make sure that we are not doing that into a secondary infection. So we do meticulous rule out of any sort of potential ECMO-acquired infections.
Yeah, no, us too. Okay.
So there have been, just to check off this topic, a lot of questions came in with respect to the ECMO, to the lung transplant criteria that we used, and what has been proposed also in that paper that I cited is that probably patients shouldn't be older than 65. They shouldn't have any serious pre-existing conditions, or at least not any that couldn't be manageable. And they, I mean, what's really key is that they must have irreversible lung damage, and that is also the most difficult question to answer, because for sure we cannot say, but we can make estimates and can interdisciplinary assess the patient with the radiologist, with the pulmonologist, with a bunch of teams to come to that conclusion, and then eventually ideally discuss with the patient, or at least with their relatives, right? What has been proposed, and I totally agree with that, if you do that, you should go for double lung transplants, because you will have to expect that in the remaining lung, if you only do one, there will be a lot of bugs remaining that will cause trouble after the transplant procedure. And ideally, the patient should be awake, not only for the purpose of consenting, but also for the purpose of working on their neuromuscular competence. And I have to say that was not possible in all of our patients. Many patients had a tidal volume of around 30, 40, 50, and whenever you would aim at decreasing the sedation, you would have so many interactions between the patient and the ECMO that virtually they wouldn't be able to stay alive, because the ECMO would be suctioning and all these things. So I still think this is about individual decision making, but these are at least some cornerstones of our considerations here. Do you have any thoughts you want to share on that? Or I know that we are kind of not in the real world in Vienna, because it's not so difficult after all for us to get organs, and we don't have to wait for 100 days.
This was exactly what I wanted to ask you, actually, about the tidal volumes in those lungs, because there's different phenotypes of the lung involvement. Some patients have very low tidal volumes, basically not able to ventilate, and the others do have a problem with ventilation and CO2 removal, things like that. So in cases where you have a very low tidal volumes, as you said, and the patient cannot be awakened actually, because it starts to interfere with ECMO, starts to interfere with the ventilator and the saturations even on ECMO. And to be honest, we have a patient right now here on 2 ECMOs at the same moment. They're still not able to oxygenate adequately if we try to awaken the patient. So you just keep him sedated, and regardless of tidal volumes, go ahead with lung transplant.
Yes, this is what we have been doing several times, and the majority of patients that I have been seeing persisted in that very low tidal volume state. But again, I want to really stress that the low tidal itself per se is not the main indication for transplantation. It's about the time course. I mean, how many patients have all of us seen with a tidal of 50 on ECMO that walk out of the hospital 5 or 6 weeks later, right? So this is not the flag that is telling you which patient may become a candidate.
If I may add a comment, I think that honestly, we are not really aware of the real potential of lung recovery. I think this is a very, very basic and fundamental information that we know. We know from the experience in Baltimore about 600 days of the patient, of the young 12-year-old girl waiting for lung transplant, at the very end improving and recovering almost completely with the lung function and parenchyma. So do we really know what is the extent of, let's say, of the waiting time? The issue is the patient going to have a single organ dysfunction, how long it will remain this status, and how long we have to, let's say, stay safe without ECMO-related complications. These, I think, all these, as Jan said, the phenotype of a lung, let's say, compromise and damage. At the same time, what is the potential and the likelihood of recovery of the lung in that particular patient, and also what about the ECMO-related complications? So this is really a mixture of factors that it's really a puzzle, but sometimes we find the pieces, sometimes we really are missing the last piece. That is the problem.
I have been discussing with Brijesh the other day and Brijesh, maybe you want to comment on that as well. Our feeling is that the patients that we are stuck with currently, if you want to call it like that, it's not a nice term, but we have a lot of patients that have been apparently on ECMO for ages. They seem not to come off prior to the end of the second month on ECMO. Rich, what's your perspective?
Yeah. No, I mean the second wave. I think the fact that they've had a lot of the therapies already has completely changed their immune system, and it's completely modulated their airway immunity, is the honest truth. So what we see 2-3 months in is significant fibrosis. So the volumes don't really matter. It's just really poor lung compliance anyway. Very difficult interactions with the ventilator. Really difficult waking them up, and then avoiding any ECMO interactions as well. And so I think that's the biggest challenge. I mean, one of the studies that Peter alluded to that we're doing and that we're able to do on ECMO is taking bronchial brushes and aligning that with radiology and transcriptomics. So that's data that we're collecting just to try to understand how odd this is. I think we don't, we saw it with flu, long ECMO runs. Usually if you're older, if you're younger, you tend to regenerate quicker and faster. And I think COVID is just a very different, it's a very novel way in which it causes lung damage, particularly in the long term. I suppose the other thing I think we have to think about that we don't have data yet is in the context of a pandemic, how much ventilator-associated lung injury occurred actually prior to going on to ECMO, and also the non-invasive ventilation use, the extremely high levels of oxygen that were delivered even through high nasal high flow. And so I think all of these things need to be kind of aligned, and unfortunately it's only retrospective data that we can use. I think whilst we've got prospective trials on NIV, and measuring ventilator-associated lung injury is very challenging prior to ECMO.
It's like the role of an early ECMO instead of long-lasting non-invasive ventilation of mechanical ventilation. That's really made this potential controversy even more important, I would say, in our clinical practice. Could really an early ECMO implant avoid all the destruction we could have with non-invasive ventilation and subsequent with the mechanical ventilation? This is really something that the pandemic made us aware that we should do also this kind of study.
Completely agree. We had a couple of patients on awake ECMO. However, I have to admit that not all of them, made it on just an ECMO, and they ultimately had to be intubated. But maybe the later intubation and keeping them breathing spontaneously may have reduced a little bit of ventilator-induced lung injury, but just a very small ETA. So maybe it's a good topic for the research.
All right. I'm afraid that there are still some questions that we weren't able to answer that came from the audience, some of that rather general, some more detailed. I think I can offer that all of us are readily available by email. You will find our data somewhere on the internet. Please go ahead and get in touch. I would like to thank the faculty for being here for all of us today. And I would also like to understand this webinar as sort of an appetizer for an event that's coming up and that's going to be huge and important. That's the EuroELSO Annual Congress from May 5 to May 7. I'm very sure that the majority of you have already registered, but for the very few that have not, this is your chance. Still some time coming up. You find on the slide also our social media channels where you can get fresh information all around the clock. And I would finally want to make you aware of a project. Next slide, please, Victoria, on which is going on and is in the final leg of accomplishing everything.
I linked it in the recording as I don't have the slide available right now. Okay.
Okay. Jan, do you want to comment on Justina's project to remind everyone to participate?
That's a project named Generate Project, and this is a multi-center project. We are trying to get the data from all European centers on ECMO provision. So again, you are kindly welcome to join this this activity, because it is important, as Roberto showed, as Brijesh showed. Only multi-center cooperation is the future for us, and what happened is completely new, and we need to get new information. We need to analyze data. We need to reassure ourselves that we are doing the correct interventions, that we aren't harming patients by whatever we can talk about, whether it is mechanical ventilation or ECMO. So this is extremely important. So I'm kindly inviting everybody. And now you had a chance to get a flavor of our Congress, which is going to come in 14 days. So just join us, and I hope we can get a lot of new information and a lot of new discussions.
Okay, so thank you all of you again for joining our audience, our renowned speakers. Thank you so much. And now please all go back to your ICUs and make sure that your venous line is blueberry and your arterial line is cherryberry. Bye-bye.
Bye.
Bye.
Thank you. Thank you. Bye.